Hello, everyone. It's a great pleasure to meet you all in this session. And in this session, we're going to have an introduction to CyberPatient, and we're going to hear Dr. Karim Qayumi's speech and Dr. Shahriar Hosseinzadeh on CyberPatient. I want to invite Dr. Shahriar to introduce Dr. Qayumi and himself, and then if you have any question, please type your questions in the chat box or raise your hands to answer your questions. Yes, Dr. Shahriar, please.
Thank you so much, Dr. Bigdeli. So good morning, good afternoon, and good evening to all my dear colleagues and educators all around the world. My name is Dr. Hosseinzadeh, and I am moderating this session. First, I would like to welcome you all and thank everyone for attending in this webinar. My special thanks to Dr. Shabi from Sadiq International Virtual University and also CyberPatient team for hosting the session. I know you are all busy and it's difficult to take time away from your daily task for meeting. We have an hour session with 10 to 15 minute Q&A at the end. Please feel free to drop your question in the chat box. The topic for this talk is about discussion on instructional strategies and developing online learning for blended learning. And we are honored to having Dr. Karim Qayumi for this talk. Dr. Qayumi boasts 50 years of teaching experience, and he is an award-winning innovator, entrepreneur, and teacher. He has achieved many accomplishments as a director of research for cardiovascular surgery, editor-in-chief of Journal of Investigative Surgery, founder and director of the Center of Excellence for Simulation, Education, and Innovation at the University of British Columbia. He is the chair of Technology-Enabled Learning and regional director for Royal College of Physicians and Surgeons of Canada. Dr. Qayumi is also the founder and CEO of the Can Health International, a registered Canadian nonprofit charity that aims to equalize health education between developed and developing countries. Thank you, Dr. Karim, for accepting the invitation. The floor is yours.
Okay, thank you very much, Dr. Shahriar, for a very good introduction and for the invitation for this presentation. I guess for the interest of time, I would just like to thank everybody who is who's present in this discussion, and I hope we're going to have a fruitful discussion. So without any delay, I would like to start the presentation because time is very limited for us, right? Today, I believe I was asked to talk about CyberPatient, but before talking about CyberPatient, I thought it's important to understand about the virtual medical education, because I think this event is organized mostly by universities who are into virtual medical education. So to start this discussion, perhaps what I would like to do is to have the main goal of our discussion, which would be very simple. Is virtual medical education visible? If it is, what would be the most effective strategy to do that? But before coming to that discussion, I would like to confirm three very important learning objectives for our discussion that would include the understanding about the curriculum, about instructional design and in developing online learning, and also maybe talk about the tools and technologies available for virtual education. And I will concentrate at that time on CyberPatient itself.
So
let's
Karim,
start. Yes.
sorry for interruption. Do you have any presentation, like slides?
Yes.
Okay. Could you please share your screen?
Oh my God. Okay. So, okay, just 1 second. I guess that's my fault. I didn't share my screen. Okay. Just 1 second. Okay, here we go. I have two. Okay, here we go. Now, can you see my
Perfect.
screen?
Yes.
Okay, great. Excellent. So let me go now to my slides. Okay. Are you okay now?
Yes, thank you.
Okay, great. No problem. So first, we're going to start about the understanding of the curriculum, what curriculum is. Many people have different opinion about the origin of the curriculum or what curriculum means. Some people think curriculum is a body of knowledge. Some other people think that it's a menu of opportunities. Some people think curriculum is a content or syllabus, we call it also. Or some people think it's a guide for educational process. In many universities, actually, they think that curriculum is a vehicle, a program in which a school or a university reach their purposes. But if we look into the history, the word curriculum is coming from ancient Greece. And the word is coming from the verb to cur. To cur means to run. So the word curriculum was used in ancient Greeks when there was a competition of chariots and the horses were going around the stadium in completing a circle. Once the circle is completed, they will call it a curriculum. And 2 circles, 2 curriculum, 3 circles, 3 curriculum. But it was John Bobbitt, actually, Franklin Bobbitt, who has used the word curriculum first in education. Because before Bobbitt, education was a teacher-centered process, and the teacher were in full control of the teaching environment and learning environment, and they did whatever they wanted to. They could teach today something and tomorrow something else. It would be depending on their mood or on their wishes, and so and they were treated as a god, and there were no checks and balances on education. But Bobbitt said that learning is a planned and guided process, and we have to specify in advance what we are seeking to achieve, and how we have to say how we're going to deliver it, what to do about it, and how we're going to assess to see if our learning objectives are reached. So introducing this circle of for teachers and for education as a whole to have a learning objective and then deliver that learning objective, and also to assess and see if we reach that learning objectives. So the full circle to come back to the same point. That's why he called it a curriculum. It's a process. So it's in simple ways. What he did is he revolutionized education. Actually, he made a cultural shift in education, and nobody actually recognized him up until 1949, when Taylor started talking about the concept of curriculum. And in the 80s, Kerr and others tried to understand it better and actually implement it into education. So to have education as a process. People also have different views of curriculum. And the views of the curriculum directly relates to the views of knowledge of Aristotle, Greek philosophers, as you have perhaps all know. So Aristotle categorized knowledge into 3 disciplines. The theoretical, he called theoria, the practical, he called poiesis, and the productive, sorry, you call it poiesis, and the practical, you call it praxis. Based on this philosophy of Aristotle, people have also 4 different type of views on curriculum. Some people view curriculum as a body of knowledge. Some people view curriculum as an attempt to achieve outcome. And some people view curriculum as an educational process, what's happening in the classroom. And some people as praxis, practical deliberation. So I'm just going to give you a few understanding of these 4 different types of views so that we would understand a bit better. People who views curriculum as a body of knowledge or theoretical, they think that curriculum is the content. And that's perhaps all the people before 1970, people thought, oh, I have a curriculum. What they meant actually to have, they have a syllabus for the curriculum, not the curriculum. But they viewed curriculum as a body of knowledge. In the 60s and 70s, new ideas come about vocationalism and vocational schools or competency-based education, where the people viewed curriculum as an outcome to achieve outcome, and that's the that's how the competency-based education in medicine came later on. But the productive curriculum was designed perhaps in the 60s, and it included the learning objectives to set, a plan to draw, then apply that plan, and then measure the outcomes. So people who look at curriculum as a process, for them it's important what's happening in the classroom. So in the classroom, we have the interaction between teacher, student, and knowledge. So curriculum, that's why they believe curriculum happens in the classroom. It's not about the knowledge you give to the students to deliver. It's not about the outcome measures. It's people are learning in interaction with the teacher and students in the classroom, understanding what the knowledge is. The 4th group of people who views curriculum as praxis or practical deliberation, they think that actually the 3 important elements of teacher-student knowledge is not enough for the education. There are other factors that would affect the education, and they call it milieu. And that would include a lot of things, including the economics, gender relationship, teacher-student relationship, social relationship, and so on and so forth. Their argument was that the person who comes to the classroom with empty stomach in comparison to the student who had bread and butter and milk in the morning coming to school is different. The condition of a person who worked all night in a factory to afford his education to the person who slept all night in a nice bed is different. So our relationship with our students are different. We have favorite students, non-favorite students. And also our relationship with respect to the gender, to girls or to boys, are different. So all these milieus are factors that would affect the education. So the people who views curriculum as praxis, they think milieu is an important factor. And Philip Jackson actually called this a hidden curriculum. So if you look at the modern view of a curriculum, curriculum has a few important components. It's the needs assessment. You have to know why you're teaching. Is there a need for your learning process? And then you have to define your learning objectives. You have to have a content. You have to have a method of delivery. You have to have assessment methods. And also you have to evaluate your process in the end. But remember that in all these components, learning objectives are central, because everything else will come back to your learning objective to close that circle of curriculum. So if your learning objectives should reflect, your content should reflect your learning objectives. Your method delivery should reflect your learning objectives. Your assessment strategies should reflect your learning objectives. So I will not talk about other part of the curriculum because it's going to be another lecture, but the most important part, as I said, is learning objectives. So it's important also now to know how to make that learning objective that would pedagogically sound. So there are two important factors to consider. One is the domain of learning, and the other is learning outcomes or level of achievement you want to have after your classroom or after your education process. So for domain of learning, you have to consider three important pillars: is cognitive, affective, and psychomotor. And for learning outcomes and the level of our learning outcomes, people usually uses Bloom's taxonomy. I love it, but there are other taxonomies that you can use. So now that we know a little bit, I scratched just the surface of what curriculum is. I hope I could deliver the message for you what the curriculum is. We are going to start talking about instructional design. In order to design a curriculum, from my point of view, you have three important pillars. It's education psychology, task analysis, and instructional design methodologies. Educational psychology is huge, and again, it will require many more lectures. But in brief, you have to identify your educational psychology or educational philosophies, whether you're following behaviorism, cognitivism, constructivism, adult learning theories, theories of multiple intelligences, or whatever other theories you're following. You have to identify and first make sure that you know what you're doing. And then the most important issues that I like to touch base a little bit on would be task analysis in instructional design. So task analysis actually is a detailed examination of an observable activities associated with the execution or completion of a required function or unit of work. So this is just a book definition of task analysis. I can tell you what it means. Task analysis actually was not developed by a scientist or a pedagogue or a doctor or a teacher. It developed by a businessman. His name was Frederick Taylor. In the theory is called now scientific management theory. What Frederick Taylor was a businessman, and he saw that his factory is not producing constantly. Every day the production is up or down, and he couldn't point finger to a person or to a process that was in default. So what he says, no, I cannot do this anymore. Let's think about how we can divide the whole production process into specific tasks, and then divide that specific task to smaller tasks up until we get to the bottom denominator, which he called entry point or entry behavior. So for example, if you are making a car, let's say somebody is making a division is making a door of a car. So what are the tasks that included in the making the door of a car? So the task would be to put the metal together and electrical things, and then in electrical things, there are circuits and there are wires. And so he was going down to that path. And then he was giving every entry point to one person responsible for. So if something did not happen in the production, then he could come back and pinpoint on a specific person who didn't do their job. So since 80s, the scientific management theory of Frederick Taylor is used in education, because we can take actually a curriculum and divide it into specific parts, and each part then divide a specific task, and each task we can go to smaller to the bottom denominator, or to the entering to the point of entry or entering behavior. This is more practiced and more used when we start doing competency-based education. So the second thing that I promised to talk to you about was instructional design. So for instructional design, in normal situation in the past, you had also three factors. It's content, learner, and method of delivery. However, today, with the development of technology, and particularly online technology is becoming the fourth pillar of instructional design. With this diagram, I try to make sure that you would understand how it relates to each other. Like the pillars that we call educational methodology, content, and learner, but technology is in the center of this. So for example, if you choose your philosophy as an adult learning, you have to use adaptive hypermedia technology. If you use the theory of multiple intelligence, then you use multimedia technology. If you use the constructivism theory of Piaget, then you can use mostly simulation or SPs or others. So with the introduction of technology, now you have to not only think about the content, about the learner, and about the method of educational method of delivery, but then you have to connect all this together with technology and how the technology would affect each of these factors. The other important thing in curriculum development is that in curriculum development and delivery, we pay attention on efficacy and innovation. So these are the most important factors that affect the adaptation corridor, how the students would learn. Now, if there is a balance between innovation and efficiency, then the adaptation corridor is straight and it's going up, and people will be learning in a specific balance. But if there is more emphasis on efficiency, then we skew this corridor toward efficiency and not toward innovation. And in fact, most curricula in the world are about efficiency. They're all emphasizing on efficiency. And medicine, or even other universities, even K-12 education, they make more emphasis on efficiency. What it means that we're examining people, examining, so that they know they become very efficient on answering questions in exams, but when they go to the real life, they don't know how to apply that knowledge because we didn't allow them to do any innovation. Actually, in medicine, most of the time we punish students for innovation. How many times in the OR somebody is trying to be innovative or holding the instrument different way or tying the knots differently, and I come and go and say, what are you doing there? Don't do that. Do it the way exactly I told you. So this means that I am killing the innovation in this person. So he will become a robot of being efficient on a specific task, but he doesn't have that when he grows up and he becomes a doctor, a surgeon, we already killed the innovation in him. So it's important in curriculum development that you have efficiency and innovation on an equal basis. So today we are talking more about the competency-based education. particularly in medical schools nowadays, all over the world, competency-based education is very important. And you would see, you will hear a lot of things about milestones and APAs and things like that. And it's at times it's so confusing because people think, well, what is a milestone and what? So milestones is an observable marker of someone's ability along a developmental continuum. So what it means is that it is the minimum task or the bottom denominator. You remember I told you about in scientific management theory. So milestone is that bottom denominator. That is the most important cornerstone of a curriculum, because many milestones together then form an EPA, entrustable professional activities. And then many EPAs then would form a rotation. So just to give you an example, maybe to understand it better, I am just gonna see if I can explain it. Let's say if you have an educational unit of rotation, so what this would do is that the most important part would be your milestones. And your milestones, you have to give to your students educational environment that would include cognitive, psychomotor, and affective. And then you have to have functional competencies to ask them specifics of what they should do to reach that milestone. And then you have core competencies. I put here as a purple CC. In core competencies are general competencies that a university or a college would like you to have. Like in our case in Canada, with the Royal College of Physicians and Surgeons of Canada have CanMed competencies. So there are 6 pillars that every doctor who graduates from Canada in every aspects of medicine and whatever he does, he has to apply those cornerstones. So in order to just give you an example, let me see for you to understand. So the starting point is the milestone. So what we do is for example, if we have a educational rotation in internal medicine, and in this rotation, we would like to have the EPAs for history taking, for physical examination. We have EPAs for decision making, differential diagnosis, management, therapy, follow-up, all those things, right? Patient transfer, we have documentation. So we have many of those EPAs. But then every of those EPAs would consist of several milestones, right? So, for example, one of the milestones could be physical examination, right? So general physical examination, if that is the milestone, then we have to deliver knowledge to the students to learn how to do physical examination. We have to provide the environment for them, a patient, a virtual patient, an SP, or any other things, so that he can practice on and learn more. And then we also to do the psychomotor function, and also to provide a reasonable environment in understanding for students to like that physical examination, to have a positive attitude toward that physical examination, so they would know the value of physical examination, and that would be the effective part of the curriculum delivery. Now, once we deliver all these things to the students to learn physical examination, then we need to do some functional competencies. And those functional competencies include, for example, vital signs, palpation, percussion, and auscultation, just as an example. And then, a student, in order to learn physical examination, we have to provide them with all that information. And also they have to understand how to do the vital signs and how to do palpation, how to do percussion, how to do auscultation in order to learn physical examination. And all that would be in the context of medical experts which is core competencies in Canada, professional communicators, and scholars. So when you palpate a patient, how compassionate you are with the patient? Do you consider the safety of the patient? As a medical expert, do you know how to do that? As a professional, how do you behave? And as a communicator, how do you communicate with your patient in doing that? So those are the most important part of the competency-based education. And when you do the assessment of the milestones, also in competency-based education, you do the assessment of milestones. And in the assessment of milestones, you consider the functional competencies, core competencies, as well as the knowledge in relation to those competencies. So competency-based education is not something new. It's actually about experiential learning. And experiential learning is a process of learning through experience. It's not learning by experience. It's learning by doing, actually. In the concept of learning by doing was proposed by Swiss pedagogue Piaget, and it's called theory of constructivism. So Piaget once said that learning is secondary to and dependent upon progressive reorganization of cognitive function. To teach, Piaget said, is not to reshape behavior, but to provide the environment for students to self-explore. So also our practical medical education or competency-based education is not mainly on transfer of learning, a transfer of knowledge. It's based on transfer of learning. The difference that there is, the transfer of knowledge is from one person to another person, and transfer of learning is from the same person to the same person. It's how our prior experience affect our new experience or future experiences that we are going to have. In it was proposed as a recall recognition theory by Hoffding. So what it means actually is that Hoffding actually proposed the theory of identical elements. So what he was saying is that if we did something in the past, in our brain somewhere, that some neurons in nodes in pathways would cluster together and form a semantic network, and it would be stored somewhere in our brain. So when the next time we do the same thing, then we don't have to think even about it. We go and reach from the library of a semantic network in our brain, and we repeat the same thing without even thinking about it. But the question came here, like how, yes, it's true if they're identical, but how if it's a little bit, if the present experience or future experience is a bit different than the past experience we have. So, and then people develop the cognitive theory of transfer, and they would say that the transfer of learning is not based on identical similarities. It's based on conceptual similarities. So Chan in 1993 actually published an outstanding paper. You can read that, and after that, there was many other papers were published after him. He actually developed the cognitive stages of transfer, and he identified 4 stages of transfer. It's orientation, coaching, tuning, and routinization. So, for example, I'll give you an example. As a surgeon, I always give my surgical example. If I'm going to the classroom and teaching my student knot tying techniques, they already know how to tie their shoelaces. So they have some semantic network there by doing all their life, they're tying their shoelaces. Now, when I come and explain to them about the complexity of surgical knots, then the brain goes and bring those information or those semantic networks that have similarities, that conceptually similar to that. And then in the process of orientation, they recognize, oh, I know that, but this is new. I don't know how to do that. And then I'm gonna do the coaching with him and take their hands, and then they do the knot tying techniques, and there's more neurons and more pathways would solidify with the one that was there before. And then they practice for tuning and to make it more precise. So you lose some of those neurons and some of those network components, and new component networks would be solidified up until it becomes a routine for you. What's called routinization or solidification of knowledge for students. And then you don't think, actually, you do the knot tying without thinking, like you have seen surgeons doing like 100 knots in 5 minutes with not thinking about it. Now, the problem with medical education is that all these 4 stages of transfer is happening in the OR or in the with the patient in the ward, which is very expensive, time-consuming, and also it jeopardizes the safety of the patient. Now, what we are proposing is that if we can take the first 3 stages of orientation, coaching, and tuning, which is the most dangerous time for the patient, and do this in a virtual simulation environment or in a lab or other places outside the clinics, and then we can go, once we know that they are now fine-tuned, their psychomotor skills, their cognitive skills, everything they have is fine-tuned now, and they can do this task or this competency, then we can transfer them to clinics so that they can practice really on patients without harming them, and would make the education process much more effective. Now, this way, if we bring all 3 first stages of transfer in the virtual environment, I think medical education would greatly benefit from that, and the patients would be more safe. So now that we talked a little bit about the instructional design, we can talk about tools and technologies. So there are many tools and technologies in the virtual environment for medical education. There's hundreds and thousands. So I don't want to talk about all of them, but I try to categorize them for you. And in my understanding, we could categorize or classify this into 4 different classes. It's digitized information, which include digital text and video and web objects and interactive web objects, and a learning environment, which includes learning management systems. There's many of them now out there, virtual classroom and virtual chat room that could be text chat or voice or even video. We can have virtual simulation where we can learn the skills in low fidelity virtual simulators, or maybe high fidelity virtual patient simulators, and gamified platforms are a thing of the future. We're just embarking on those. So coming back to CyberPatient, as I promised to you, CyberPatient belongs to that category of high fidelity virtual patient simulation. So actually what CyberPatient is, it's a virtual hospital with 135 digitally enhanced patients that are available for you 24/7. And your students can go at any time and reach those patients, practice on them without any ethical or legal consequences. And it's 10% of the cost of an SP. Actually, the research has shown that. And also what you can do with CyberPatient that you cannot do with other platforms, that you can go into the whole continuum of care, from history taking to physical examination, investigations, diagnosis, treatment, and prognosis of the patient. CyberPatient also provides great pedagogical values. And just to list a few, I can say that it's student-centered, it's a competency-based education, it's accommodates style of learning, improve decision-making abilities, improve experiential learning, learning by doing, improves compiled thinking of transfer of learning, and provides a solid base for transfer of learning. So we have done a huge number of research projects with CyberPatient. Many of them was done in Japan in the past, that you see here, that shows CyberPatient is much more significantly better than traditional learning, particularly for those for lower achievers, not higher achievers. We have also done to compare CyberPatient with standardized patient, and it looks like it is better than a standardized patient, but it's also 90% cheaper than a standardized patient. In Kazan State Medical University, they have did the assessment of students after using CyberPatient, and in the opinion of students is that it has a measurable 90%, close to 90% impact on their medical practice. So there are much more papers are coming into publication. 2 papers from the Shahid Beheshti University in Tehran, Iran, and also the Virtual University of Iran have published outstanding papers that shows that the benefits of CyberPatient. You can, just for the interest of time, I'm just going to go fast, but you can read those papers. I encourage you to go and read those papers. And also the Virtual University Medical School in Iran did a summer school for students, and the results are outstanding. They're in the process of organizing it and publishing it. In Kazan State Medical University, actually, they did also a very good study that where they because of the COVID-19, most of the students, some of the students could not come from outside into the country, so they gave them CyberPatient, and the ones who were in Kazan State Medical University, they gave them traditional methods, and they saw that people who use CyberPatient, it shift the mediocre students into a higher achiever students. In Bulgaria, Kostadin is a PhD student who actually looked at the knowledge retention with CyberPatient in comparison to the traditional and also to high fidelity physical simulator, and he found that it's equivalent. It increases significantly more than traditional methods, and it's equal to high fidelity simulator. However, the knowledge retention is significantly better with CyberPatient from both methods. So I think we're coming to the end of our discussion or my presentation for you. So we talked about the curriculum, what curriculum is and how curriculum is developed. And also we talked about some other technologies available for virtual medical education, including CyberPatient. Now I would like to have an interactive, if possible, discussion with you guys to answer these 2 important fundamental questions. Is virtual medical education visible? And what will be the most effective strategy if they are? So I don't have actually a pooling thing so that I can ask you these questions, but I don't know if you can raise your hands, because it's a webinar. You cannot raise your hands either. But let me tell you my opinion, and you can think about it yourself as also. So in my opinion, when you look at all the technologies that I described for you, taking into consideration our technologies, I believe that virtual medical education is, if we think about virtual medical education without any other methods, it's at this point, it's impossible. It's mainly impossible because we don't have the physical or virtual technologies that would replace a patient. Nothing would replace a patient. Even technologies that we have right now, like the high fidelity virtual simulation that we have, CyberPatient, it has its limitations because technology has its limitations. To make this like a real human being, to palpate and to actually do it, theoretically it's possible, but the technology is not there. So you have to have a very high fidelity 3D environment that would require enormous amount of computational power that we don't have now. And perhaps for the next 50 years, we will not going to be able to have it. And then you have to have haptic technology developed so fine so that you can go inside the computer screen and actually feel the tissue and feel the tumor and feel the hardness of the abdominal wall or whatever you want to do. So at this point, perhaps the best thing is to do a blended virtual education. So all virtual universities, from my perspective, it's an outstanding idea to have a virtual medical university, but should have a blended curriculum. So what I'm saying for blended is that we have the outstanding now digital information. We can deliver digital information, no problem. We can have a digital environment, no problem. We can have virtual classrooms and so on and so forth. But when it comes to the high fidelity simulation, when it comes to patient experience, we have to send the students then to a hospital to get the real experience with the real patient. Now, what I would say that the most closest, but perhaps the most advanced education that would use technology is aviation, in the aviation industry. Aviation industry is perhaps the gold standard at this point for medical schools to look for. In aviation industry, to train a pilot, 70 to 75% of their curriculum is on simulator. But they have very, very sophisticated simulators. I have been in one of those simulators in Montreal because Canadians CAA company called CAA has the best simulator in the world. And I have been in the plane, and I have been flying actually a plane. It is so realistic that's unbelievable. I don't want to take much of your time, but it is it's a whole other experience. Now, so if 75% of their learning is on simulators, the other 25 or 30% of their learning is now not on lectures and things. It's mostly now on virtual environment. So if we improve the digitized information in virtual learning environment, and we adopt that from aviation industry, and also to take to build virtual simulators that would be very close to reality, then yes, slowly we could move toward virtual medical education. But I think it is very important that these virtual medical schools are around, and they are working on it. They're collaborating worldwide. But in my understanding, it would be nice to have the aviation industry as a gold standard in work toward that direction. At this point, I would like to thank you very much for your patience dealing with me. And if you have any questions, we have some time to entertain.
Thank
Dr.
you, Dr.
Shahriar, can you unmute Dr. Hosseinzadeh, who's a surgeon just like Dr. Qayumi, and he posted something very interesting, and I also concur because I'm a surgeon, that the surgeon's finger is his third eye. How do you overcome that in virtual learning? You still have to feel and palpate.
Exactly.
Hosseinzadeh might come.
Exactly. You're absolutely right. That's what I'm saying. You need
Yeah.
haptic technology. If you don't have haptic technology, you cannot have that. And to bring the haptic technology is not very mature technology, even in the labs. If you take it out of the labs into the real world, is a lot of work has to be done for that to happen. Although we have technologies like we can shake hands overseas, we can feel each other hands overseas through the computer. There was a company, a surgical company, who made Da Vinci and Zeus. But Zeus was the one who was using haptic technology to do surgery from distance. So that finger that you're talking, and they were planning actually to use to do a surgery, a cholecystectomy, in France from New York. Okay, the patient was in France and they were in New York. Actually, I went there and I used their technology. It was amazing. It was amazing technology. But they were very unfortunate because they planned this, spent millions and millions of dollars to plan this experiment, to publicize it. And they planned it at the time of 9/11. So nobody watched them. So their company bankrupt, and Zeus bought their company. So it's a business money thing, but it's not that there is no technology out there. The technology is not mature yet.
Could I just ask you one question before I hand over to
Please.
Shahriar again? That the software that you've developed, is it available in the market? And what about the developing countries? Because Sadiq International Virtual University is basically, it represents the developing countries. And there are lots of medical doctors, teachers, professors who join us. Will this software be available to them, and will it be subsidized by your organization?
Yes, absolutely. The CyberPatient is a commercial entity, and it has been commercialized a year ago. It's just recently commercialized, and it's available for anybody. And yes, we do have subsidies for developing nations. We will work together with them to find money, but we need their enthusiasm and their willingness to use CyberPatient in their curriculum. And as soon as we do that, then we can do a major subsidy to support them. And also we will help them to apply for grants to the United Nations, to other places, to support their education, and also to the other industries. There's money available in other industries, medical industries, that would support, like pharmaceuticals and others, that supports medical education. So this would be a good program. So we will work together. If anybody's out there would like to do that, please contact my office. My numbers are there. Kathy, Mark, and me, we're going to be available to hear you and support you and help you to use CyberPatient for your purposes.
Thank you.
Thank you, Dr. Qayumi and Professor Shabi. So we have a few questions in the Q&A, and also we have two raised hand in the chat box. So first I start with the questions. So the first question is from Shalini Sivanji. Sorry if I pronounce your name wrong. And it says the difference between efficiency and efficacy in relation to curriculum development.
Yeah, difference between efficiency. Okay, so efficiency means assessment of it's defined by assessment of your curriculum. So if you do exams and every minute and every seconds, every day, like the students are on their toe to do things the way you wanted them to do, and in the end they become efficient, no problem, right? When they pass the exam, you score them as efficient. But what my problem is, or the word of pedagogy problem is, are they becoming the slave of your ideas? Did they have the opportunity to bring their own ideas in making the education environment richer by thinking, not following? That's the question.
Thank you. So another question is from anonymous attendee. So it says, you mentioned the imbalance between efficiency and innovation in medical education. And I have found that there is often a hesitancy to implement newer technology from program leadership. What is your experience with promoting innovation and addressing the hesitancy?
Yeah, promoting innovation is one way of bringing innovation, but you're bringing innovation from other environment into your process, and that's the department. Your department is doing that, and that's a very good thing to do. I'm not against that. But what we're talking about innovation is to give the students the opportunity to be innovative, to do more research, to do more thinking, to give them liberty to express themselves. We seldom don't give liberty to students to express themselves.
Okay, thank you. Another question is from Shalin Sivanji. Are simulators same as CyberPatients?
All simulators are?
No, are simulators same as CyberPatients?
Yeah, CyberPatient is a simulator. Yeah, CyberPatient is a virtual simulator. As I said, it's a virtual hospital with digitally enhanced patients in it, and they can simulate any kind of conditions you think, which is part of your curriculum. Not every condition, but the specific conditions that you learn in medical school. It's about 135 cases.
So another question from my dear colleague Dara Albane, and it says, dear professor, we appreciate your informative presentation. I just have a question about the pass score level for competency-based skill in medical practice.
Well, the scores are different by different universities and different organizations. The scores are determined not by us. Some people have the score of 65 to 70, 75 to 50 to 80. In my opinion, a score of less than 75% should not be allowed to go for practice.
Thank you. So we have another question from Dr. Wahid Mehrnoush, and it says, is there a potential for CyberPatient in future to map out the thought process of medical students and provide feedback to them to have a better self-evaluation in terms of their thought model?
Yes, we are in the process of doing actually that. We do that in a way. We have an intelligent tutoring system in CyberPatient. So when the students are interacting with CyberPatient, the intelligent tutoring system calculates all the mistakes and good things and the bad things that he does. And in the end, we have a page where the student can see what he has done, and we gave them a feedback like what he should have done, but that he did not do. And the next time we go through the same CyberPatient, he would remember that he has to give this drug, for example, or this method of investigation and so on. However, having said that, we are gathering all the information from the users in putting it through the artificial intelligence of machine learning, so that we can learn the patterns of students making mistakes, and so that we can give them much better feedback, and much better in design a curriculum more toward the style of learning. So Kolb's theory, yes, we do that, but it takes time. It takes a lot of time. This is not something that you could put in the computer. This is something that you have to wait. Like, you remember Siri? Like, you have to now wait. Millions of people will use Siri, and the Siri would get every day better and better because of the machine learning, artificial intelligence.
Thank you, Dr. Qayumi. I have another question from Professor Mulazim Hossein Bukhari, and it is how we are looking the virtual medical education in the era of the artificial intelligence.
Yes, as I said, we're the artificial intelligence is going to enter the virtual environment, but it's very much in infancy at this time. Actually, CyberPatient is the only product in the market right now, or even in the research laboratories, who uses artificial intelligence to support the virtual environment. We have just completed a major project with NRC, it's National Research Council of Canada, for implementing a voice recognition system and two-way communication system using artificial intelligence for CyberPatients. So within the next few months, you're not going to be able to you're going to be able to click to get answer from the CyberPatient, from the avatars in the computer, but now we are able to actually talk to the avatar. We can ask them to sit down, walk around, come close to me, lay down, turn your back, so we can actually talk to the avatar. We also finished the development of delivering a bad news, exercising to deliver a bad news to a patient through a two-way communication artificial intelligence system. So we are working on those areas. I think next week, one of our star students from South Africa, is doing a research project on artificial intelligence in CyberPatients. So yes, you're right, absolutely. Artificial intelligence is very important to introduce, but it's not as easy. It's easy to said than done. So we are working on it, and we are moving forward toward that direction.
So another good question from Dr. Wahid Mehnoush. Is CyberPatient tracking the mistakes by students, faults, as might be source of innovation? As you know, some innovation roots in finding faults in defaults.
Yes, CyberPatient already does that. CyberPatient already, as I said, it has an intelligent tutoring system that calculates all the mistakes of the students and give feedback to the students in the end of the session.
So I had raised hand. I'm not sure if Dr. Abdul Razak Sheikh got the answer. I cannot see your hand again. Did you get your answer? Okay, so another question is from Shalin Sivanji. Is ASCII a type of the assessment for CyberPatient?
Sorry?
Is ASCII a type of assessment for CyberPatients?
Yeah. Actually, you could replace ASCII with CyberPatient. CyberPatient is an outstanding tool for us to be used as an SP, as a standardized patient. And right now for ASCIIs, you use standardized patient, but you can also use CyberPatient for ASCIIs. Much more sophisticated and much less expensive.
Thank you so much. And the last question in the Q&A box from Dr. Abida Shahin. And it says, thank you for the excellent presentation, Dr. Karim Qayumi. It's always a pleasure listening to you. I wanted to ask that could there be role of the students in designing virtual curriculum, as they are considered the most tech-savvy generation? If yes, what could be the pros and cons of their involvement while designing curriculum?
Yeah, I believe the students should be involved in designing of any curriculum, virtual or non-virtual. I mean, students are an integral part of the process. And I think it's all positive for students to bring their experience, bring their technical knowledge, bring their willingness, and also the interest. You remember we're talking about cognitive, psychomotor, and affective. I mean, bringing us students to develop the students to bring their own curriculum. They're going to be very passionate about that curriculum. They will like that curriculum because they're an integral part of it. And in fact, in North America, in Canada, every curriculum committee has a medical student in it. Every curriculum committee has a medical student in it. So it's not, there is no negative side on it. The only part of the curriculum that should not be exposed to students are the assessment part. So if you have the exam questions and things like that, that is something secret, and that's something that the dean's office should keep it in a locked place and so on and so forth. Otherwise, you know, the students' input would be very important for development.
I have another raised question from Dr. Mahmoud Asif Moghal. He raised the hand. Dr. Moghal, do you want to talk? I can allow you to talk. Please talk. Dr. Mahmoud Asif Moghal.
He's muted, perhaps.
Please unmute yourself and talk.
Yeah, unmute yourself, please.
Talking permitted. Please just unmute yourself.
Can you unmute him? Or Kathy, can you unmute him?
I cannot.
I have tried. The invitation has been extended to unmute Dr. Mohammed Asif Moghal.
Oh, he is unmute now. Please ask your question, Dr. Moghal. Okay. So probably that's a technical issue. So yeah. Dr. Moghal, can you please just maybe text in the Q&A box for the question?
Okay. So
I think we answer all of the questions. Dr. Wahid Mehrnoush still have a question, Dr. Qayumi, and he said, is CyberPatient compatible with non-competency by design the education systems?
Yes. You know what competency by design means is that Royal College has this process where the competencies in different level in a lifetime of a person should support the medical education. So in lifetime of a person, like in different levels, let's say after finishing medical school, entering to residency training program, finishing, it's one level, and then finishing residency training program, it's another level, going to practice every 5 years, is another level up until he retires. So competency by design means that we have to provide the environment for them to be able to test in their competencies or learn new competencies on each level of learning, on each stage of their life. That's what competency design means, actually. But to answer your question more precisely, yes, CyberPatient can be used in competency by design. Actually, this CyberPatient 2.5 that we have is the first product that we developed, and this is developed for undergraduate and nursing schools. But we have now 5 other products that would cover other areas and gaps in medical education. And one of those is maintenance of competency. So we are now working with the Royal College of Physicians and Surgeons of Canada, and we received a $500,000 grant from NRC, National Research Council of Canada, and also Canadian Space Agency to develop, to adapt CyberPatient for maintenance of competency for astronauts, a flight crew that goes to deep space missions for 5 years or more, so that they may, when they go to these deep space flight missions, they may forget their competencies, or they lose their competencies that they learned in medical school on Earth. So they have asked us to develop a systems, a maintenance of competency education system with CyberPatient, so that they can use that during the flight and practicing in maintaining their competencies. And now we're using this also for Earth here. So we are working on this new software that would support the maintenance of competency for each stages of life of a person. We also have another product for team training. It's like a game. It's like a computer game with several people. So what the issue is here, that several people, like a team of people, can work on a patient in a patient avatar in the cyberspace, and they will control their avatars in the cyberspace, moving around and doing things, intubating patient and doing resuscitation and all that, and also can do the debriefing later on, and they will be in communication with each other. So this is the next product we're developing. We'll have tons of other things that are coming that is out of the box entirely.
So thank you, Dr. Qayumi. The last good question. So I know a little, we are a little bit out of time. So, but this is the last one. Dr. Shahriar asking for the question: how do you see the future of the CyberPatient in terms of its usage for every university with different level of the technology access?
Yes, we are. We actually designed CyberPatient for that purpose, so that people can reach it with the lowest internet, accessibility, and also we use CyberPatient. We develop CyberPatient in a way that that would be useful for everyone, although it's very difficult to make it useful, but we are ready to adapt CyberPatient to the cultural value in local pathologies that people are having. So CyberPatient is designed actually in the simplest way possible, so that you don't need any extra gadgets. You don't need any extra software. You don't need nothing. The only thing you need is a computer and a Chrome. The only thing you need a computer and a Chrome and a mediocre internet. But having said that, I am working right now to have a desktop version of CyberPatient for people who doesn't have even the mediocre internet. To just in working in Ethiopia in some of the universities to deliver where there is no internet at all, or the internet is only very expensive or very small, so that medical students can. We're trying to equalize medical education between the developing and developed nations. People are asking me usually, oh, why don't you use 3D? If I use TD, 50% of the world cannot use CyberPatient. So we have to use the simplest technology to deliver the learning objectives. That's my mission. My mission as a professor is to, how can I use technology to learn, to deliver the learning objectives?
Thank you so much for the wonderful talk, Dr. Qayumi. I think we have reached the end of the talk today.